Yeah, I only used artificial intelligence for this and one other. Right. So, I am Rebecca Peña. I'm an internal medicine resident at Son Espacios University Hospital in Spain. And today I'm going to talk to you about a case I was able to see back home a few months ago. But first of all, I would like to start by telling you a little bit about where I'm from. So, right. So my hospital is actually in Mallorca, which it's in orange right there on the map. It's the biggest of the four Balearic Islands, which are just off the eastern coast of Spain, Mediterranean. It's a very beautiful island. The top picture on the right there, you can see our capital city, which is Palma. That's the cathedral. And then we also have a very nice mountain range called the Sierra de la Tramontana, with very nice little towns dotted across it. And it's also known for very, very nice beaches all across. As for my hospital, that's Son Espacios. There are actually several hospitals on the island, but mine is the biggest. It's a tertiary academic hospital linked to the medical school, which is actually located in the same building complex. It's the referral hospital for a population of over 330,000 people, but that's actually exponentially larger, and especially during tourist season. And it's also the reference center for the four Balearic Islands for both code stroke and code MI. We have a total of, as the last data I was able to find, we have a total of a little over 820 inpatient beds, and 100 of those are reserved for internal medicine. And we also have 20 ORs and 7 smaller theaters reserved for ambulatory surgery. As for the internal medicine department, well, this is a picture of me with my fellow residents a few years ago. As is the case for many of the bigger hospitals in Spain, internal medicine is actually divided into several subspecialized areas. For our case, that would be infectious diseases, systemic autoimmune diseases, general medicine, a multi-morbidity unit, which takes care of more old geriatric patients with several comorbidities that appreciate sometimes some conservative management. We also have a rare diseases unit, an ambulatory medicine unit, whose goal is to search for alternatives to conventional hospitalization. And we have 2 inpatient referral units, so other departments in the hospital can consult on their patients with us when it's divided into general medicine and infectious diseases cases. So as for the infectious diseases unit, we have an inpatient ward with just under 30 beds. The referral units, we also have a daily antimicrobial stewardship meeting with microbiology, surgery department, and anesthesiology departments. We have a day hospital for early discharge patients or patients who require IV treatments and do not necessarily need to stay at the hospital for this. And an outpatient clinic, which is differentiated into general infectious disease and also some specialized units for HIV, microbial infections, tropical diseases, and the vascular infections and bone infections. Well, now that you know a little bit about my hospital and where I'm from, I'll start with the case. Chose this title for it, and well, we have a 74-year-old man with no drug allergies. He's an ex-smoker. He's currently retired, but remains very physically active, going on daily long hikes in the Sierra. He has no cognitive dysfunction, and his medical history is most relevant for arterial hypertension, dyslipidemia, type 2 diabetes mellitus, chronic kidney disease, secondary to in the context of cardiorenal syndrome with his chronic congestive heart failure. And also, interestingly, since 2025, he has been found to have pancytopenia, mild pancytopenia, hepatosplenomegaly, which was attributed to the congestive heart disease. They actually did a liver biopsy, and the findings were consistent only with congestion. Well, this is, let's see if this works. This is an image of this CT scan. Oh, okay. Yeah. Right. The main thing to see here is the hepatomegaly and the splenomegaly. There's a little zebra pattern That's the immediate physiologic, the face of the contrast. And you actually see there. And the
examination is like that's exploded.
yeah. And it wasn't, he actually had an abdominal CT scan from 2024, but that was his present. He also has a pretty complex cardiac history, which I've done my best to summarize for you, which is mainly marked by progressive recurrent mitral regurgitation, which started in the year 2017, complicated by repeated episodes of acute heart failure, despite multiple attempts at repair, two attempts at surgical repair, and also in the last year, he also had two episodes of alveolar hemorrhage, for which he had a very comprehensive study with a PET CT scan, for which there were no significant findings, and also an extensive autoimmune and infectious workup, which had no significant findings at the time. Since, despite the two surgical repairs, he again had to be admitted for pulmonary edema. He was eventually referred to our hospital again for a percutaneous repair at this time. During the admission was marked by persistent fever without an obvious source. Serial blood cultures were negative, as well as other studies. He also presented with mildly elevated liver enzymes and a pancytopenia, which he already had, but it was worsened. And looking back on testing done on his previous admission, which we imagine was since the results weren't readily available still when he was discharged from the previous hospital, as part of his workup, he had elevated titers for Coxiella Burneti, both for phase 1 antigens and phase 2 antigens. At this point, the cardiology team chose to refer to our infectious disease units. Good. Well, this point, yeah. Well, this is just an image of his this mitral regurg prior to the percutaneous there. This is after both surgical repairs. Very not moderate to severe, very severe mitral regurgitation. No other findings. This is the total, but they also did TTE. They saw no vegetations or anything else. Your question? Sorry, this is just there. So when this patient was referred to us, the first thing we did was review all the testing that had already been done previously, and we went back to the patient and took a complete history again. So when we spoke to him, he described a 1-year history of constitutional symptoms with marked weight loss of up to 3 kilograms and profuse night sweats with no documented fever. The patient, he was from Mallorca, had lived there all his life, lived with his wife in the Sawyer Mountains, in the mountain range of La Sierra, with close contact with farm animals, mainly sheep and goats. He didn't have any himself, but he was in close contact with them and did not actually help his neighbors with earthing, but his area surrounded by many pasture fields with these animals. He had no recent travel history, no sick contacts, no pets, and no other significant exposures. When we asked him about the results of the acute fever, he had not heard of this at all, had not received treatment, and there were no documented previous episodes of acute fever in his history. We have electronic medical records, so we were able to go back a long time. We also actually ordered a PCR in blood, which was positive at this time, and we eventually decided not to order another PET CT scan because he had a relatively recent one with no significant findings. We went back over the TTE and the toe with a cardiologist now that we had this result, because I'll go over later, Coxiella endocarditis doesn't usually manifest with the usual findings you would expect. In focal endocarditis, it's hard to see vegetations, but they found nothing that was very significant for them. And well, before I continue with the case, I'm going to go a little bit into the epidemiology of the microorganism.
Can I ask what your differential diagnosis was?
Well,
Before you knew Coxiella.
It's from the moment he was referred to it. I mean, the reason for the referral was that the cardiologist that had this patient looked over the results and saw this. That's why he called us. So we started from there actually. And then we went back and asked them to see if there was a relevant exposure, compatible exposure and compatible symptoms.
Do you know why they checked for that?
And this was actually done at another hospital, and they did this as part of the workup when he already had the hepatosplenomegaly, which had been there previously, and the weight loss. So they did this as part of the workup, and as well, they were also looking for a cause of the continued failures with the mitral regurg despite the surgical repair. So they did that as part of the workup.
Do you have leishmaniasis in
Yes,
Mallorca?
yes.
So you didn't consider that?
I think they did this for that.
Well, pancytopenia.
Yeah, and hepatosplenomegaly, yes, that's the would be one of the first things you have. Yeah, great. Unfortunately, I don't have access to the data from here, it's capped. But from what I remember, yeah, but we obviously want to think we would check and that is negative, yeah.
Because there's not a lot of causes of like massive splenomegaly that crosses the midline. And I mean, we always think of leishmaniasis and schistosomiasis. I mean, there's a few
Tropical.
tropical
Just they doesn't tend to cause massive. I mean, it's tropical splenomegaly, myelofibrosis, fibrosis,
But that would not be a concern with him because he had traveled outside of the country. And for leishmania, that would be a concern because we do have leishmania as well.
Okay, interesting.
Right, so on the left, the graph on the left is, there's actually not a whole lot of data about incidence and endemicity of fever because there's a lot of infra-notification. It is mandatory to notify cases in infected animals. It is not mandatory in most places to notify cases for infected humans, and also many cases are asymptomatic or very mildly symptomatic, so they're never diagnosed. On the left, you see the major human epidemics due to acute fever between 1950 and 2019 all over the world. Many of them most of them concentrated in Europe. And on the map on the right is from the ECDC, and this is the distribution of confirmed acute fever cases by country as of 2019. I haven't found any later reports for some reason. Apparently, they stopped doing this, but as you can see, Spain actually has a pretty high burden of disease. And we also know that Coxiella is endemic in Mallorca specifically, and so we went back and did a retrospective analysis of a case series that we had from 2017 to 2022, if I remember correctly, and looked back on all the confirmed cases that we had of acute fever, and which you can see here in the graph, and we actually found a very, very high incidence, more than expected and more than reported previously, especially if you compare this to what has been reported in countries traditionally thought to be a high incidence, such as Bulgaria. They reported an incidence of 0.41 or 0.45 cases per 100,000 people, and the global incidence reported in Spain is actually 0.31, which is a lot lower than what we found in this short period. Right. So, well, I'm not gonna talk too much about the bug. It's a gram-negative bacillus, and during its life cycle, it has two different morphologies. One is the metabolically active one, which has to live inside the host cell, and the other one is a small spore-like formation, which is very heat resistant and can survive outside of the host cell. And this can actually travel for many kilometers from the source, carried by the wind. It's been described to be able to travel even up to 19 kilometers. So even if you are not in direct contact with these animals, you can still get the infection. And since Mallorca is a very small island, really everybody is exposed. So the mechanism of transmission for humans is mainly inhalation or direct contact with inhalation of the spores, or direct contact with birthing products of the mainly goats and sheep, and also cattle. And although they're having cases of infection due to ingestion of infected milk or milk products. the livestock can get it from tick bites, but not humans. You need intermediate reservoir. The incubation period can be from 2 to 4 weeks, and next. So we start from exposure. Those that are exposed, you can get a primary infection. The majority of those will be asymptomatic, and around 40% can be symptomatic, but 95 to 98% of those will not be diagnosed because the symptomatology can be very, very mild. 2 to 5% can present with severe symptoms and require hospitalization. The most frequent symptoms are usually high self-limited fevers, myalgias, but sometimes patients can present most typically with pneumonia or hepatitis. There's actually an uneven distribution of this geographically, like in terms of Spain, we see mainly pneumonia in the south, and in Mallorca, we see mainly hepatitis. Once you have the acute infection, only 1 to 5% of people will then go into a latent phase, and where the infection can reappear months to years later. So chronic infection, which can actually have a very high mortality if left untreated. And some of the risk factors for this will be immunocompromised states, pregnancy, and also prior valvulopathy. And especially patients with prior valvulopathy will be at higher risk of developing endocarditis. So as for diagnoses, we mainly rely on serology. For acute infection, we look at IgM and IgG against phase 2 antigens for seroconversion. And for chronic infection, we look at the phase 1, which is more virulent. We can also rely on PCR and blood and serum and other tissues, which can be positive within the first week or 2 weeks of acute fever. And also about the PCR, it's also important to note that it can also be positive in the setting of chronic acute fever. And this is actually indicative of probably recurrent bacteremia. And when you have a positive PCR in blood, up to 33 to 60% of patients that have positive PCR in blood have been documented to have persistent localized infection in endocarditis. And you can also do next generation sequencing if you can afford it. And then for the CDC case definitions of chronic fever, we need microbiological confirmation, but you also need clinical evidence of infection to be able to say this is a case of chronic fever. And we mainly can rely on the Dutch consensus guidelines for this. These arose as a result of a major outbreak they had in the southern parts of the Netherlands between 2007 and 2011, where over 4,000 symptomatic cases were reported. And they set it down like this. You can have proven chronic acute fever, which our patient doesn't really meet criteria for this, or probable chronic acute fever, which is where our patient would be, because we meet the serologic criteria. We also have going back to, in order to have a proven chronic acute fever, you would need a positive PCR as a serologic, and you would also need to meet definite endocarditis criteria due to the modified criteria in our patient, both on the original modified criteria and the 2023 update. He only meets criteria for possible infectious endocarditis. It's also important to note that, as I said earlier, findings on cardiac ultrasound in acute fever endocarditis are absent very often or non-specific. And the most common finding is actually valvular insufficiency or severely worsening valvular insufficiency. This leads to very long diagnostic delays oftentimes. So going back, our patient has the serologic finding, the valvulopathy not meeting the modified KIP criteria, and he also has symptoms and signs of chronic infection with the fever, the weight loss, the night sweats, the hepatosplenomegaly. He also had raised CRP. There are also there's another group from France that offers alternative diagnostic guidelines that I wrote, and they actually yeah. And
it's been largely discredited.
And just we rely on the Dutch guidelines, but
yeah.
And they actually don't like the term chronic acute fever, so they will divide it into acute fever endocarditis or acute fever vascular infection. Our patient only meets possible criteria, possible acute fever endocarditis criteria, and he does meet definite criteria for acute fever vascular infection. I thought this was interesting. This is a relatively recent article. It's from 2023, if I remember correctly, in which they proposed a new definition for acute endocarditis in the setting of acute fever because they were concerned lots of these cases were being missed. For this, they went back and analyzed 2,400 patients with a positive serology for Coxiella from their French National Registry, and out of these, they found 48 cases of acute fever endocarditis. And with this, they proposed a new definition for this, which is you need to find a new valvular image lesion less than 3 months after an episode of acute fever, plus you must meet the microbiologic criteria. With this, they proposed the algorithm you can see on the right for the diagnosis of acute fever endocarditis. So going back to our patients, our working diagnosis was actually probable chronic acute fever with a persistence of the list infection and a possible endocarditis secondary to chronic acute fever. I did have like a nagging question at the end of the case, like originally going back, the mitral regurgitation he had originally because we had etiology possibly a result of an acute fever episode that was undiagnosed because he was asymptomatic or very mildly symptomatic. And what we're seeing now is actually persistent endocarditis and not endocarditis secondary to chronic acute fever. In either case, the treatment is the same at this stage. We started him on hydrochloroquine and doxycycline and discharged after ensuring adequate tolerance, and our planned treatment duration has to be very long, at least 18 months, determining the antibody titer every 3 months with a plan to maintain treatment until we see a fourfold decrease in the IgG antigens against phase 1 and clinical recovery, and then with a bi-yearly follow-up for at least 5 years to ensure no relapse. And so far, I would have one follow-up visit for this patient, month after discharge. He still had no drop in titers, but we wouldn't expect that at this point. They actually measured the hydrochloroquine plasma levels, which are in range, and the patient was clinically better, no more fever, no more night sweats. And just briefly on infection prevention and control, there is a vaccine for livestock, which is an inactivated vaccine against the phase 1 antigen, which is quite effective. And for humans, there's also a vaccine, but it is only commercially available in Australia. It is an inactivated whole cell vaccine with a high reported efficacy. However, it is restricted due to severe reactogenicity in previously sensitized individuals, and there are new vaccines approaches, vaccines in development, which aim to reduce the reactogenicity without losing efficacy. And finally, for me take-home messages, acute fever, as we know, should be for the differential diagnosis of prolonged fever and blood culture negative endocarditis. Chronic acute fever endocarditis, it has very absent or very subtle findings on TT and toe, so this would not rule it out. Predisposing the structural valve disease, prosthetic materials, and exposure history are major clues, and the diagnosis depends on integrating both the history, the serology, the PCR when available, and imaging. And well, it's also very important to note that if we miss this diagnosis, there are potential high morbidity and mortality costs for people. Very much.